Hi, James.
Hi, Ori.
So who's the chairperson for this session? Do you know?
I don't know. You know?
No, I don't know. It didn't have it listed.
I think we are the judges. But,
hello, Professor Watt, Professor Trill, and I will help the conference go
All
through.
right.
Yeah.
Right. Thank you. Thanks.
Thank you.
So I'll come back in a couple of minutes. Yeah.
Okay. Thank you.
So is it a poster hall? Which poster hall is it? Poster hall 2, right? Poster hall 2.
This is hall
2, yes.
hall 2, yeah.
It should be hall 2. So may I know how's the presentation of the poster? So would all the students present, yes or no?
For every participant, they have 5 minutes and 3 minutes for oral presentation and 2 minutes for answers.
3 minutes presentation.
Yeah.
And 2 minutes Q&A.
Yeah.
Oh, so quick. So quick.
Yeah.
So would all of you turn on your camera? May I ask? All the participants will turn on camera?
Depends.
I think
open.
Yeah, because I think the regulation in my instruction, it mentioned that you need to ask all the participants to open camera, and at least here they need to check their voice.
Okay, for all the participants, if you want to test your microphone and video, you can do at present. We will start the poster session at 2 p.m.
12, right?
Yeah. Oh, 12. Sorry.
So I see Liu Yun. Hi, John. Can you speak as test your microphone?
Yes, I think my microphone is okay.
Yeah, very good, very good.
Okay, thank you.
Right, and how about some other participants, right?
Yeah. Rui Yuan.
Yeah, I can listen.
Yes, very good.
You may share your PPT and one by one. Let's wait.
Yeah, one by one. So who is going to present first? May I know?
Liu Yun.
John, right? John will be the first one, and then the second one will.
Yes, I will be the first one.
Yes, the second one will be the Hui Liu Ling, right?
Hui Liu Ling, yeah.
Yeah, can you try your microphone? Yes.
Hui Liu Ling.
Yeah. Yes, I can hear you. Very good. Next will be Danata Chao Have Wang, right?
Yeah.
So where is him?
I didn't see him.
Okay, but yeah.
Next.
So and then will be another John.
John A.
Yes. Adil, and then we have you, right, Weijia, and
Yeah. Could you, Hui Liu Ling, could you turn off the screen you shared?
yeah, can you turn off the screen sharing?
Share.
Yes, okay, we can see. Very
Yeah.
good.
Okay. 好 ，next。于
Ichikawa,
Ichikawa.
he's not here, right? So maybe next.
Maybe next.
Tree.
Tree.
Tree mean train, right?
Yeah.
Yes. Did you hear me?
Yes.
Yeah.
Okay, I will share my poster.
Yeah, try first before we start, okay?
Could you rename your show name as your registered?
You see my poster?
Yes.
Yes.
Okay.
Thank you.
Okay, next. Sharing Tan.
Sharon Tan is not here, right?
Yeah. Okay, next one.
Ruyan
Ruiyuan.
or Zhi Tinghui.
Ruiyuan. Dr. Ray. Dr. Yuan. Do you want to test your microphone and screen? Okay, maybe not here.
Okay, so is it only these? No others, right?
Yeah.
Okay, good. Seven presentation, right? No. Okay.
Good afternoon, everyone. Welcome to participate the IDR SEA conference. And this is the poster session, Hall 2. Let's welcome the first presenter. Dr. Niu, please share your screen, open your microphone. Dr. Niu.
Hello.
Hello. Okay.
Mm.
You can start your press.
Okay. Good afternoon, Chairman and colleagues. It is my honor to share my research with you. My research investigates the anti-biofilm and the remineralizing effects of the dual-action peptide GAKR12 on artificial enamel caries. Our previous study developed a novel dual-action peptide by grafting gallic acid and KR12 named GAKR12. It can inhibit planktonic karyogenic species growth. In addition, it can remineralize initial enamel lesions in a chemical model. To further demonstrate the efficiency of GAKR12, we adopted a biochemical model in this study, which combines biological and chemical factors to mimic an oral environment. Artificial lesions were created on 44 enamel blocks by S mutants before the 21-day S mutants biofilm remineralization cycles. During the cycling procedure, enamel blocks were daily treated with GAKR12 or water as control. The assessment of biofilm and enamel tissue were conducted separately. This table,
Is there something wrong?
Yes, I will share my screen again.
Okay.
Okay, this table summarizes the viability and the growth kinetic of S mutants in the biofilm of the two groups. The results revealed that the bacterial count of peptide-treated biofilm was significantly lower than that of control. In addition, we can see more red fluorescence of S mutants biofilm on the peptide-treated enamel surface than control, which means most of the bacterial cells were dead in the peptide-treated biofilm. SEM showed confluent growth of S mutants in the control group, but not in the GAKR12 treated group. In addition, cells of S mutants treated with GAKR12 exhibit morphological defects. This table shows that the calcium to phosphorus molar ratio of the peptide-treated enamel were significantly higher than that of the control, and the lesion depth and mineral loss of the peptide-treated enamel was significantly lower than that of the control. The surface morphology revealed a relatively smooth surface with a uniform remineralized prismatic pattern on the peptide-treated enamel. In conclusion, this in vitro study demonstrated that the novel dual-action peptide GAKR12 inhibited the growth of S mutants biofilm and enhanced the remineralization of artificial enamel caries. Thank you very much for your attention. Take care and keep health. Any questions, please? Thank you.
Thank you, Dr. Niu. Any questions?
I can maybe start. So thanks for that, John. That's very interesting.
Yes,
But
thank you.
there seems to be a few details missing that maybe you didn't put in due to space or something like that. So could you give a little detail about the peptide? Where does that come from? Is it based on a cathelicidin or is it something else?
Yes, the GA is a gallic acid, and the KR12 is a sequence from a human peptide named LL37.
Right. So that would have been, so I think that's a derivative of cathelicidin, is it?
Yes, the LL30, sorry.
I think,
Yeah.
I was just wondering, I think LL37 is a derivative of a cathelicidin, antimicrobial peptide CAMP.
Oh,
Is
yes.
that right?
Oh, yes.
Yeah. So just how has this been studied before, or were you the first? Was this the first time that these components have been put together?
Sorry.
I'm saying, is this the first time the activities of this peptide have been studied, or have these been studied before? Were you the person that thought to put these things together?
Oh, yes. Put them together is the first time. Some study previously investigate the antibacterial properties of KR12. So I think it should be a very, very good template peptide for me to grafting the gallic acid to develop a dual action peptide.
So I'm wondering if you considered using another control, because your control is water. So
yes,
you've got two components together. Did you think of using either just the peptide or just the GA component as other controls?
Yes, maybe you can find a previous paper I just published in the Journal of Dentistry in the August this year. In that study, I compare gallic acid, the only peptide KR12, and water and JKR12 in that paper. In this paper, I used another carriers model, so I just only compare the JKR12 and water.
Right.
Thank you.
Thank you.
Thank you.
Thank you. Thank you for Dr. Niu. Let's come to second participant, Dr.
Bye-bye.
Hui.
Yeah.
Dr. Hui, could you share your screen?
Yeah.
Okay, you can start.
Oh, okay. Good afternoon, everyone. My name is Hui Lin, and I'll be presenting linear and angular measurements in lymphoid-1 osteotomy with tuberosity cut using CBCT. Lymphoid-1 osteotomy is the most common osteognathing surgery for correcting dental facial deformities involving maxilla. It comprises 3 horizontal cuts and 1 vertical cut. Tuberosity cut is one of the modifications for the vertical cut. This cut may avoid damaging the descending palatine artery, ultimately presenting severe vascular complications. However, there is still no consensus on how and where to put the osteotomy during the surgery. So our study was designed to measure the possible sides and angles for tuberosity cut, as well as linear measurement for 3 horizontal cuts using CBCT. In this study, 189 CBCT screens were included between 2016 and 2020 in our institution. We included patients who were over 18, presenting first and second maxillary molars, without history of surgical interventions, trauma, or tumors in the maxilla. For tuberosity cut, 6 surgical angles were measured. We selected 3 possible sites, posterior to maxillary second molar and marked as M2, M23, M3. To enhance the surgical safety, we selected another measuring point F, which is 2 mm posterior to the descending palatine foramen. Then M2F, M23F, and M3F were the 3 possible tuberosity cutting routes on CBCT scans. 6 angles were measured relative to the mid-sagittal plane AP and the posterior buccal-cortical plane MN. Linear measurements for the 3 horizontal cuts were also measured. After calculation, the results show that the mean surgical angles for tuberosity cut varied from 58 to 95 degrees relative to the mid-sagittal plane and 72 to 100 degrees relative to the buccal-cortical plane. For the horizontal cuts, it varied from 27 to 47 millimeters. Based on results, we made conclusions that when performing a tuberosity cut, an angle of 76 degrees relative to the mid-sagittal plane or 92 degrees relative to the buccal-cortical plane may be safe in avoiding the descending palatine artery in Lee Fort Wong osteotomy. That's my presentation. Thank you very much.
Thank you, Dr. Hui. Any questions?
So may I ask one question?
Yes.
Yeah.
So I know that the study is using quite young age patients, right? So 18 to 35 years old. So what do you think if this study is working in a more older population, just like after 40 or even after 50-year-old? Well, is there any difference?
Yes. I think the Lee Fort Wong osteotomy is mainly designed to correct the maxillary deformities. And nowadays, most young people are doing this surgery, and also our sample size is from these young generations. So maybe in future we have to enlarge our sample size and to do further studies about this.
So that means the older people and younger people may have different dimensions, or we say it's anthropometry. Do you agree?
I don't think they will have big differences, but based on our sample size, most of our patients are from young people. So maybe in the future we will do a bit more a big sample size.
Okay, thank you.
Thank you, Dr. Hui. Let's move on the next. Could you, Dr. Hui, could you turn off the share the screen? And Dr. Chu Huawen, could you open your microphone? Yeah. Okay, you can start your presentation. We cannot hear you.
Sorry. Okay. Can you hear me? Okay.
It's okay now.
Okay. Good afternoon, everyone. My name is Darren Thananthachawang. I'm from the University of Hong Kong. Today, I'd like to share the topic about a systematic review of topical anti-illusive agents on dental erosions. Today, nowadays, the incidence of dental erosion has significantly increased over past few decades. But the study of the topical anti-illusive agents have been seen in the literature. Then the objective of this study was to provide an overview of the anti-illusive agent for non-operative management of dental erosion. I will talk about the methods, but this systematic review was performed, followed by the PISMA 2020 and PICO and search info databases. And finally, 61 full-text articles about in vivo, in situ, and clinical study were included for analysis. For the results, 61 included article had 15 topical anti-illusive agents and it can be divided into 3 groups. The table 1 shows the names of the anti-illusive agent in each group. The first group is commercially available fluoride agents such as the sodium fluoride and standard fluoride. The second group is commercially available non-fluoride agents such as PPACP, arginine, and chitosan. The last group is non-commercially available experimental agents such as titanium tetafluoride. For the table 2, show 8 topical anti-illusive agents that are available in the market and provide the delivery system and concentration of active ingredients that have been investigated in included articles. Although most of these available agents have not been used for dental erosion prevention, but this agent provided many promising results to protect tooth from dental erosion in the research. And for the positive mechanism of topical anti-illusive agents are summarized in table 3, or 15 agents had the same mechanism of absorbing and forming the layer on the tooth surface. Some of them enhance buffering capacity, modify salivary pellicles. For the conclusions, this systematically will purport 15 topical anti-illusive agents. With the limitation of this study, is unable to conduct a meta-analysis. It had to be kept in mind. Current evidence reported inconsistent and limited results to support using this agent in clinical studies. Therefore, further studies are required to perform and prove the effectiveness of topical anti-illusive agents with the homogeneous protocol. Thank you very much.
Thank you. Any question?
I can ask one. So thank you,
Yes.
Darren, for that. So what's the next step? So you've done this analysis now. So you've mentioned clinical studies. So what's your next step?
Yeah, I have planned to do the in situ study, focus on the combination of the fluorides, SDF and amine fluoride to modify the salivary pellicle on the tooth surface to get more erosion resistant in the future.
So what do you mean by modify the salivary pellicle?
For my project to modify the salivary pellicle, because some of fluoride can modify the pellicle and increase the good protection.
Right. Thanks.
Thank you.
Yeah,
Thank you.
maybe I ask one very quick question, okay?
Okay.
And I see your table 2, your stainless fluoride and the amine fluoride, right? So so one is a mouth ring is 250 ppm, and another one is 1450. Both are AMF stainless fluoride, right? So how do you do this kind of classification? Why you think the 251 is the SNF2, the stainless fluoride, and the 1451 you classify is amine fluoride one? How can you do the classification?
Yes, I classify by the objective of the included article. It's just like from the title. Yeah, they have some misleading. That you ask me.
Yeah, you need to be cautious.
Okay.
I think not that they sometimes they combine that formula are not that easy to classify, but you need to find a way to classify as well.
Okay, thank you for your advice. Thank you.
Thank you.
Thank you. Let's go on. The next presenter, Dr. John.
I'm
Here?
here.
Yeah. You can share your screen.
Okay. Yeah, can you see my screen now?
Yeah, you can
Okay.
start.
Okay. Hello, everyone. I'm John, and I'll be presenting salivary methylome analysis in oral cancer to unravel differentially mediated regions for non-invasive diagnosis. Oral cancer is more common than other head and neck malignancies, and it has a survival rate of 50%. Now, the survival rate can improve if patients' recurrent lesions and primary lesions are detected early. But the diagnostic protocol almost completely relies on tissue biopsy, even in screening and treatment monitoring settings. Now, tissue biopsy is good, but in inexperienced hands, it may be not representative. Or during the monitoring journey, there are a lot of false positive lesions that will require biopsy, which may be deemed unnecessary. Now, salivary liquid biopsy has the potential to circumvent some of these limitations, and aberrant methylation markers represent one of the most promising group of markers used. But the thing is, there has been no direct discovery using saliva, biomarker discovery using saliva, and a true whole genome approach to detect dynamic deregulation signatures. So we designed a study that aimed to characterize and annotate differentially methylated regions and genes that may be useful for oral cancer diagnosis and future inquiries using saliva and a whole genome approach. We selected 8 samples randomly from our saliva bank, and 4 of these patients had oral mucosal disease, and 4 had oral cancer. We extracted DNA from them, quantified it, and performed quality check using spectrophotometry, fluorometry, and gel electrophoresis. We process the sample for a whole genome-wide approach that targets mainly the CPG sites which are involved in methylation, titled the reduced representation by sulfide sequencing, after which we then perform standard methylation calling and comparative bioinformatic analysis. So we found a total of 148,143 differentially methylated CPG sites between these two groups, and found 1,823 differentially methylated regions, with each region being about 100 base pair long. The highest proportion of these CPG sites and regions were within chromosome 20. When we performed two-dimensional hierarchical clustering, we found out that the differentially methylated regions could delineate oral cancer from oral mucosal disease, and most of these differentially methylated regions were within the promoter site. We then moved to check the gene arrangement using overrepresentational analysis to characterize the genes associated with differentially methylated region, and found out that most of them were involved in cell junction assembly and pattern specification. And upon KEGG pathway analysis, we found 19 genes that were significantly enriched in the EPO signaling pathway. So this led us to conclude that indeed we can use genome-wide techniques like RRBS and whole genome bisulfite sequencing for biomarker discovery in oral cancer, and that differentially methylated regions in the salivary methylome may involve genes that control cell or cell matrix adhesion and pattern specification. And this will prove useful for future targeted inquiries and research. Thank you. That's my presentation, and I will welcome any questions or suggestions.
Thank you. Thank you, Adoy. Any questions?
Thank you, John. I can maybe ask a couple of questions.
Okay,
so,
thank you, Dr. Rory.
You have eight subjects and a lot of different data. How confident are you that your results are, well, how confident are you with your results regarding how do you do your filtering and things like this?
Okay, this is preliminary data, but we tried as much as possible to be stringent with our analysis as possible. First, we reduced the methylation because the saliva is quite heterogeneous. So we reduced the level of mean methylation difference between the two groups. Then made sure that each read that was sequenced had a Phred score of Q30, and 88% of the sequence reads, filtered reads rather, from each patient had about a Phred score of Q30. So then we made sure that when we compared the two groups, we actually used those that had a Q score, that's false discovery rate adjusted p-values of less than 0.01 to obtain this result. So it was quite stringent. We understood that the samples may be heterogeneous and saliva itself is heterogeneous, but we tried as much as possible to be stringent with the analysis.
So if I can ask thanks
Yeah.
for that. So if I can ask
Yeah.
a follow-up question. So what's the next step? Are you able to extend the study, or do you need to get funding that you can extend?
Yes, we sent a second, we've done a second analysis using more patients now. We got 12 patients extra, yeah, to confirm these results. So we are hoping that it correlates with this one. And even with this result, we can, because the role of the EPO signaling pathway, for instance, which is usually turned off when cancer is about to migrate or proliferate. Yeah, the role of epigenetic control has not really been investigated. So it also gives us an additional thing to look at in terms of the mechanism of cell migration, cell survival, and cell proliferation in oral cancer. So it goes both ways. We're hoping to validate this result and also do like a mechanistic study to explain why EPO signaling pathway is enriched in the saliva of oral cancer patients.
Right. Thank you.
Yeah. Thank you, Dr. Watt.
Thank you. Let's go on. The next presenter is me. Let's share my screen. Okay. Good afternoon. My title is Changes in Parental Oral Health Attitude in a 2-year dental carers program. This is a longitudinal analysis of data from a 2-year randomized control trial. At baseline, all the parents will receive the individualized oral health education, and a questionnaire was used to collect the parental oral health attitude at baseline and 2-year follow-up. At baseline, the infants were at 1 year old, and at 2-year follow-up, the children were 3 years old. A total of 472 parents and children completed the 2-year program. And there were some aspects of parental oral health attitude for adults' oral health and the children's oral health have been improved. Less parents thought loss of teeth was a natural process. On that hand, more caregivers were thought dental problem could affect the whole body. As to the parental oral health attitude for children's oral health, more parents thought they were able to brush their children's teeth and knew how to brush their children's teeth properly. On the other hand, less caregivers thought it's not able to brush children's teeth when they fell asleep, and less caregivers thought they would not force if their children does not want to brush teeth. So this is just a part of the results from the randomized clinical control. From these simple questions, we know parents had improved their oral health attitude after receiving the individualized oral health education, and they were more motivated to keep oral hygiene for their children. Thank you very much. It's a very simple study. Any questions? Mm-hmm.
So, thanks, Widya. Can I ask something? So in the abstract, you say 2 different kinds of toothpaste, but I'm not sure what those were.
Yeah. We used subtle toothpaste and fluoride toothpaste. Since this is a dental caries prevention program, we want to compare the effectiveness of subtle toothpaste and fluoride toothpaste. Since when we applying the fluoride toothpaste with high concentration on young children, there is the risk of dental fluorosis. So we want to try to find another products to replace the high concentration of fluoride toothpaste to prevent the dental caries.
So, if I can follow up, was it a sponsored study? Was it a funded? Was it funded commercially or not?
Found what? Sorry.
I'm just saying, was it sponsored by the company, or was there any commercial interest in the study, or not at all?
This is funded by GRF.
Oh, right. Thanks.
Yeah, thank you.
Yeah, may I ask one very quick question? So the emphasis is this individualized OHE. So if I mean there are some oral health education which is not individualized, but is it the individualized is something very important?
Sorry, let me explain more. It's a standard oral health education to all of the caregivers at baseline, but just one by one. Not gathering all of them and to give a speech. We just do the oral health education one by one.
Okay, I see. Okay, thank you.
Thank you very much. So let's go on. The next presenter, Dr. Lichikawa. Dr. Lichikawa?
Yeah, sorry.
Could you share your screen?
Okay.
Okay.
Good afternoon. I'm Yu Ichikawa. The title of a poster is Root Caries Risk Assessment Measuring Salivary IgA Specific to PAC 361 to 386. In the Superinic Society of Japan, root caries is a problem among older adults. It tends to be difficult to treat, so evaluating the risk of root caries and preventing it is essential. Streptococcus mutans, one of the main causative bacteria of root caries, has a PAC protein antigen on its surface that is involved in initial attachment to the tooth surface. In this study, we determined the amount of salivary IgA antibody specific to amino acid residues 361 to 386 of S mutants PAC in all older adults to assess the root caries risk factors. We collected stimulated saliva from 389 adults aged 76 years living in Niigata City and measured salivary IgA antibody to PAC 361 to 386. After this, we referred to IgA antibody to PAC 361 to 386 as PPA. Moreover, dental examinations were conducted at the baseline and 1 year later, and the total number of untreated and treated root caries was recorded as root DFT. To assess the risk of root caries development, multivariate logistic regression analysis was performed using levels of PPA, number of S mutants, salivary flow rate, number of root exposed teeth, and gender as explanatory variables. In this study, participants with PPA below the first quartile were treated as low levels of PPA. Now I'm going to move on to the results and discussion. Table 1 presents the baseline characteristics of the participants. Table 2 shows the relationship between the increase in root DFT and each parameter. The participants with low levels of PPA is significantly higher in group with increase in root DFT. Table 3 presents the results of multivariate logistic regression analysis. After adjustment, low levels of PPA were significantly associated with increased root DFT. The adjusted odds ratio of low levels of PPA is 1.81. In conclusion, low levels of salivary IgA antibody to pH 361 to 386 may be a risk factor for occurrence of root caries in older adults. That's all. Thank you for listening. Any question?
Can I ask you a question? I noticed that you use the when you analyze the S mutant in saliva, you use log CF per swab. Why you use per swab? Why don't you use per millimeter or per microliter like that? Because other studies, most of the studies will use CFU per millimeter. Thank you.
Thank you. Your question. Sorry, I didn't catch all of that. Could you repeat your question, please? Sorry.
In your statistic analysis, you use S mutant in saliva to present. You use the log CFU per swab, right?
Mutants?
In your poster, you use log CF per swab to present the result of S mutant in saliva, right?
Saliva, yeah.
Yeah. Why don't you use per millimeter? Why you use per swab?
Yeah. You mean? I'm sorry. I still understand your question. Sorry. Could you please talk to me after the session? Sorry.
Could you look at your poster statistic analysis and the covariant S mutant in bracket log CFU per swab, right?
Yes.
Yeah, why you use per swab? Why don't you use a millimeter or microliter? Because you use the saliva, you can use the same amount of saliva to do the process. Yeah.
So sorry. After the session, I answered this issue. Sorry.
Sorry, we can talk later.
Yeah. Thank you.
Okay.
Your question.
Thank you. Any other questions? Okay, let's move on the next. Dr. Trin. Dr. Trin?
Hello,
Dr.
are you hear me?
I can hear you. Could you open your video and share the screen?
Did you see my poster?
Yeah. Okay.
Okay.
You can start.
Dear Chairman, Okay, now I'm start. Dear Chairman and colleagues, today on behalf of the research team, I present the topic of restoration of endothelially treated molars using on-ceramic endocrowns. A suitable restoration for endothelially treated teeth remains controversial topic. Endocrown is a monolithic ceramic adhesive restoration with pop chambers preparation that does not extend into the root canal. However, there was been currently very little research on this type of prosthesis. The main object of this study analyzed the clinical outcome in 1 year functional period of 56 lithium disilicate endocrine at Cần Thơ University Hospital, Vietnam, which were performed in CAD/CAM technique and assessed by modified US Public Health Service criteria. As the result, after preparation, the average of pop chamber diameter, the depth of pop chamber, and the occlusion thickness after preparation consistent with the recommendation of many authors. Average preparation time was 11.16 plus minus 1.2 minutes. And time to try-in and cementation, the restoration was 15.6 plus minus 0.7 minutes. The majority of patients were very satisfied with the mesh color, morphology, function, and feel comfortable during the treatment. When we assess restoration, most of criteria had A grade. There was only one case completely missing on the restoration at the time of evaluation after 1 year. In conclusion, endocrine was minimal, invasive, and effective method to treat molars with endodontic treatment. Thanks for your attention.
Thank you, Dr. Trio. Any questions?
So may I ask one very quick question? So what's your cavity design? Do you have an inlay design or some like an overlay design for your endocrine?
I'm decided on inlay design.
Inlay design, right?
Yeah.
Okay, so in terms of the endocrine, and you have a you try to mill, so you perhaps you also have the post to the crown should have the post simulated. So what's the size of the post that you are milling to the dimension?
Sorry, can you repeat your question?
I mean you are making the endocrine, right? So I mean when you're milling, so you also incorporate the features of the post, right? In the endocrine, right? You are not only making a crown, but you are making an endocrine, right?
Yes.
So do you have the, can you show us the design, how you make the endocrine? You know what I mean?
My design depend on the guideline of Dr. Bin, yeah, Dr. Bin, in 1999.
Okay, so it's following this old paper. Okay, I understand. Thank you.
Yeah.
Thank you. Thank you, Dr. Trio. Let's go on. The next is Dr. Tan. Okay, we can see you.
Okay, hi, can you hear me as well?
Yeah.
Okay, great.
Thank you.
Okay, so good afternoon, everyone. I'm Sharon from Nanyang Polytechnic in Singapore. So on behalf of my colleagues, I'll be presenting our study entitled Changes in Dental Environmental Stress with Home-Based Simulation Learning. So the overarching aim of our study is to determine changes in dental environmental stress and stress levels among oral health therapy students during the COVID-19 pandemic following a home-based simulation learning program. So to describe the home-based simulation learning program, it was introduced in our school during the circuit breaker period where school closures and activities were put on hold in 2020. So the staff at our school actually distributed portable mannequins phantom heads with typodons, instruments and consumables to students in all 3 cohorts of study for their use at home. The synchronized discussions and demonstrations were conducted over Zoom during scheduled time slots over 3 weeks. Each class had about 22 to 26 students in breakout rooms. 22 to 26 students. So after that, we had real-time supervision of students in groups of 6 in the breakout rooms. Our activities included soap carving, rubber dam placement, alginate mixing, operator positioning, and periodontal instrumentation using hand scalers on jaw articulators and mannequin heads. Our study population was OHT students in Singapore. An online survey using our online CDRSS platform was sent to all students in April 2020 before the HBSL program, as well as after the HBSL program of 3 weeks. We included socio-demographic characteristics and a 38-item dental environmental stress questionnaire. As the data was paired and data distribution was non-normal, we used a Wilcoxon signed rank test as well as generalized estimating equations. A response rate of 98.6% was obtained. We found that the top stressors among students during the pandemic are examinations and grades, the fear of failing the course, and the fear of being unable to catch up. An increase in DAS score with higher stress noted for the items, difficulty of classwork, competition for grades, examination and grades, difficulty in learning precision manual skills, and fear of being unable to catch up if they are behind. We found no statistically significant change in overall DAS scores before and after HBSL, although we noted a statistically significant 0.2 point increase in stress levels in the academic work domain. Year 3 students, which are the final year students, had a higher stress scores for the domains of educational environment and academic work. This is as compared to Year 1 students. In addition, no significant changes or differences in stress levels were noted across genders, ethnicities, and residence types. Our finding that academic work is the greatest contributor to DS is corroborated by other studies conducted during the COVID-19 pandemic. Stable overall DS scores of 1.3 to 1.4 or less than slight stress pre and post HBSL program may suggest that students adapt to the program over time. So this is one of the first longitudinal studies on home-based simulation learning during the pandemic. However, we have a relatively small sample size from a single school, and there may be unmeasured confounders. Nonetheless, our study provides evidence for implementation science in dental education through the evaluation of the impact of remote simulation learning on student well-being. Thank you. Welcome any questions.
May I ask a question?
Yes.
Since the final year students have more stress, will you consider some solutions or suggestions to make these conditions better? How about your further study plan?
Yes, definitely. So I think we do find that they are more stressed, and academic is one of the key stresses. So actually for our study, we have tried not to give them examinations during the home-based simulation learning program. So that was one way we've tried. The other way is also to provide more feedback. So actually in this study, we also surveyed other aspects of simulation design, and one of the key factors they raised was having enough support and feedback for their work. So I think one of the recommendations that we gave to our lecturers was also to give them more feedback, to provide them the necessary support, because it's a very novel technology or technique of teaching, having it home-based. So that was one of our recommendations. For future studies, I think it's definitely how we can expand this. We have done a low to moderate fidelity kind of simulation. So we know that we have haptic simulators, we have virtual, VR and all that, virtual reality. So that may be one of the other ways. So I think there are other studies in UK that have tried this, but they've not done it in a home-based setting. I'm not quite sure whether they've looked at stress and all that as an outcome for such techniques. So I think those can be further studies that could be carried out.
Okay, thank you. Thank you, Dr. Tai. Let's go on. Welcome our last presenter, Dr. Yuan. Dr. Yuan, you can share your screen.
Okay.
You can start.
Thank you. My name is Yuan Rui. I'm from Guanghua School of Stomatology, Sanyaseng University in China. and I'm very pleased to join this meeting. The topic of my presentation is a description of tooth loss prevalence by income level in the US. Why I choose this item? Over the past few decades, income inequality has increased dramatically in the US. In the meanwhile, the relationship between income levels and health has been well established. Social-economic status, including income levels, can also influence oral health. Even some papers have set forth the effect of income levels to the oral health, but few studies have highlighted the dynamic changes in oral health across income levels. From 1999 to 2018, the prevalence of complete tooth loss has been decreased from 29% to 13% among adults aged 65 and over. However, whether the poor and the rich have the same tendency, and what is the change of gap in tooth loss prevalence between rich and poor people under the increasing income inequality. To solve the problems, we choose data from National Health and Nutrition Examiner Survey, that is NHANES, NHANES, from 1999 to 2018, containing information of 12,481 people aged 60 to 80. This is a public database shared on the internet. Tooth loss situation was described into 3 levels, and the income level was divided into 2 levels. The richest 20% population and the remainder of the population. The tool we use is R software. The main result could be understood from 3 figures. Figure 1 shows the total population weighted tooth loss prevalence was much higher in the poorest 80% population than that in the richest 20% people. Figure 2 shows the trend of tooth loss in the prevalence of all 3 levels of tooth loss from 1999 to 2018. In addition, figure 3 shows for the poorest 80% of the population, there was a significant decreasing trend of tooth loss by several circles. Nevertheless, there was non-significant trend in the rich people. That's all. Thank you for your listening.
Thank you for Dr. Yuan. Any questions? Professor Choi, do you have any questions?
So maybe just ask something very quickly. So you are using a US database. So how about your variation is from 1998 to where to 2018, right? So in these years, is there any other changes that can lead to the tooth loss prevalence rather than only utilizing the 20 years data here? So let's say something like the nutritional or their previous medical record or their previous experience, just like whether they have been suffered from war, right? So would these kind of events would also affect the tooth loss? You understand what I mean?
Yeah, I can understand, but it's so difficult to answer.
Or how about the GDP? I always love to use a GDP. So various countries, they have different GDP, right? So would the GDP also different years, they have different GDP or different economical status that can also affect their their nutrition absorption or even the sugar consumption, or or whenever the YouTube is there, then the people just sitting in front of the YouTube and then just eat many things, right? Would this kind of social behavior or economical behavior would also affect the tooth loss? Have you considered this? Yes or no?
No.
It's all right. I just give you some idea. Yeah.
Thank you. Thank you.
You're on mute. You're on mute.
Okay. We can leave now. Thank you.
Thank you. Thank you for your time. Thank you.
Well done, presenters. Yeah.
Thank you all.
Bye-bye.
Bye-bye. Bye-bye. Okay.